Hey there, Matt Ryan here with Mike Marchek. We're going to be talking about the Wilderness Walk, which is our wilderness medicine module. That's part of our emergency medicine clerkship for EM students, and we have been doing it for about a decade now. Wilderness medicine is a natural part of emergency medicine, right? It's got critical care, emergent crises, sore conditions.
Yeah, it's just the things we have to do in practice in the ED, but just kind of on steroids out there in the wilderness there with the very
Right, and the emphasis is to just really adapt to the situation at hand. We did wilderness medicine as a sim back in the day. It was in the sim center, a very controlled environment on campus, and it was not awesome. I mean, we live in Florida.
Yeah, I mean, we have plenty of cool environmental issues that come up. Heat, cold, sometimes.
Exactly right. So this is a 2-hour experience. So we got to a park. It's for fourth-year clerkship students. It's really just the basics of what to do in a crisis when you're on a hike with your family and friends out. Alachua County has dozens of nature parks. I've also taught the class to EMS, Emerging Medical Student Association, medical students and residents.
Florida, yeah, we really are the Australia of America. We've got all sorts of amazing animals out there. Gigantic gators, wild horses, bison, you name it here. We might as well be out in the environment there and talk about things that we may encounter.
Absolutely. So instead of going to that park with a lot of alligators, we decided to go to the Devil's Millhopper, which is this beautiful state park. It's a half-mile loop around this ancient sinkhole, which is most ethereal. There's a set of steps you can go down. The thing is teeming with water moccasins. It's really bliss. The session starts with a disclaimer. We always give a disclaimer of what we are and what we're not. I'm not that guy. That's my son. He's a wilderness medicine trained firefighter paramedic. And we emphasize, what stuff do you have on you? What do you have with you? And don't forget to look around and see what else is, might provide help.
And, at the end of the day, it's still super casual. That's me wearing a Hawaiian shirt there. But at the end of the day, we do go through the basics to begin with here. BLS, using what we can in terms of basic tools at our disposal.
Yeah, and keeping the patient warm is something that's come up multiple times. My son joins me on the Wilderness Walk. He talks about how important that is really. And basically it comes down to the fact that your clotting factors are proteins, and like albumin in an egg, they are susceptible to heat and temperature changes. I love eggs, but you can't uncook an egg.
Snakes, yes. We sometimes see them actually in their natural environment out on the walk here. But just in case we don't and can't discuss real live ones, we've got the plastic variety here. Coral snakes, water moccasins.
Eastern diamond bog. Yeah, these are important snakes. They are plastic. I always have to warn the students that they're plastic because when I take them out of our bag, there might be a reaction. Unfortunately, the coral snake came alive, bit me in the neck, gnawed at my jugular, and Mike had to rip it off me. I was okay.
Stopping the bleeding is a key aspect of what we discuss, and we're not always going to have a good military-grade tourniquet at our disposal. So we discuss ways of MacGyvering things like lanyards, belts, whatever we can find at our disposal.
Here's a couple of students. They fashioned a tourniquet, so be it, out of a hoodie and a lanyard. And that's kind of, what we're aiming at. Stopping the bleeding, that's obviously the expectation, but slowing it down until you can get help because you've already called for help is the key. Here's a first aid kit that we made. Basically, I was left with this empty food container after eating a delicious chicken curry, and I realized I could make a first aid kit and use that as the container. It's got some basic suture materials, got some lidocaine, it's got some gauze. Simple.
Splinting techniques are discussed as well. We go over ways of fashioning makeshift splints out of everything from various twigs, branches lying around to maybe some academic journals that we happen to be carrying around in our backpack.
Oh, absolutely. You fold up an academic journal. Here's my favorite edition of Academic Emergency Medicine, circa 2013. But you fold that up, and that's going to provide a rigid enough device to help stabilize and prevent an injury from getting worse. As long as you have something to fasten it with, here you could use again a hoodie. This student actually fashioned a splint, MacGyvered a splint with a pair of flip-flops and a hoodie. And here, this also underscores the fact that students are both the patients and the providers as we go through the scenarios. Location is key. I think we really wanted a beautiful place to get outside, to enjoy the air, to enjoy each other's company, and to learn something, and just basically have a good time. It's a very relaxed environment, and this is just one of the paths along the Devil's Millhopper around the sinkhole, which is to the right of this picture. Students have consistently rated the Wilderness Walk pretty highly. We've been doing it for a decade. The evaluations are very positive. They like getting outside. They find it very practical. It's a socially relaxed environment. Weather, the elements, the climate is definitely a problem. And this is why we do this. This is why we go through a little bit of extra effort to provide a great experience for our students. We do it for them. We teach for them. That's our greatest currency. And I'm sure most people listening to this would agree. Thank you very much.
The metrics are garbage. Reimagining residency selection in a competency-based world. I want you to think back to your own match day, the culmination of all of your hard work in medical school, striving for honors grades, getting involved with research projects, studying for step 1 and step 2. Then you matched, and by the time you showed up for residency, none of those things mattered. In fact, study after study over the last few decades shows that none of those metrics predict your performance in residency or as a physician at all. Ultimately, they are garbage metrics for residency programs to use to stratify applicants that are ultimately meaningless for all stakeholders, but we continue to use them because we don't have any other way to get through the mountain of applications we receive each year. Not only must students strive for high marks on metrics that in the end don't matter to programs, but they also deal with significant discontinuity in the transition from medical school to residency. Medical school and residency are completely separate, and as such, programs treat students as blank slates. The lack of transparency harms a student's ability to continue to focus on their individual growth, as programs must train to the lowest common denominator. The advent of competency-based medical education has challenged traditional paradigms of assessment and the focus of medical training as a whole. CBME is designed as an outcomes-driven framework with a focus on the responsibility that medical training has to meet the needs of society. From there, it works backwards to train physicians to meet those needs. Core to CBME is the developmental progression along a continuum from day 1 to 1001 and beyond. If the focus of CBME is growth, then residency selection is the single greatest threat to that continuum. Residency selection demands that students obtain high step scores, honors grades, and tick boxes in order to secure a residency position at a desired competitive program. CBME demands continued growth along the continuum and transparency around those areas for growth in order to focus on individualized learning. Attempting to maintain an assessment system that allows for the use of these norm reference metrics that place students in competition with one another and encourages them to hide their areas for improvement cannot successfully exist in tandem with a growth-oriented system of assessment where students are encouraged to focus on areas in which they need to improve. This is akin to the phenomenon of trying to put a square peg in a round hole. It just doesn't work. So why not simply get rid of the current system? Because residency selection continues to be an arms race. There are not enough spots for the number of applicants. You may argue that we are in a place where there are enough spots in EM for every USMD graduate. However, we continue to see a steady increase in students entering the specialty. The number of applications per student continues to rise, and each student continues to interview at more and more programs. This is akin to the amassing of nuclear arms in a Cold War of residency selection, and program directors demand ways to wade through all of these applications. This leads to the perpetuation of norm reference stratification of students and competition for honors grades. This engenders an achievement goal orientation in our students. Then we tell them when they enter residency that they need to fail to learn, but they have no idea what to do with this because they have spent so much time trying to appear perfect that they don't know how to accept and integrate feedback. As such, the actualization of CBME demands a gross overhaul of our current residency selection process, as it is in diametric opposition to achieving a growth-oriented system of assessment. So how do we achieve change? First and foremost, we need to take a hard look in the mirror and own that we have participated in creating this problem. We must then partner with undergraduate medical education to investigate the current residency selection processes, including the over-reliance on current metrics to make interview and ranking decisions. We also need to take a hard look at our system because it perpetuates bias, lower socioeconomic status and ability to pay for test prep, systemic racism in honor society selection, and faculty bias in assessment and how honors grades are assigned. We must systematically address this problem. It's also time to consider diverse approaches outside of medicine to chart a path forward to align selection in CBME in order to achieve a true continuum of medical training. Using principles from the field of industrial and organizational psychology can inform these approaches. This would shift our focus to aligning selection systems with organizational culture and justifying decisions to select certain applicants based on that alignment. Programs can start by taking a look at the mission and culture of their department and being transparent with applicants about what that is and what you value as a program. You can then align your selection process to screen for applicants who align best with that mission, and then use your interview questions to probe how students will contribute to your mission and how you will be able to best meet their training needs. I don't have all of the answers, But thinking about the way forward requires investment across the continuum of educators to create a continuum for trainees. We need to talk to each other about how we can alter assessments to foster growth, align selection with those novel assessment approaches, and restructure residency selection to focus on aligning program culture and applicant selection. We owe it to our students to end the arms race and focus on their growth along the continuum. Thank you.
Hello, I'm Rebecca Levin, a second-year pediatric emergency medicine fellow at Brown University. Today, I'd like to talk about an improved QI curriculum we've designed that we feel can benefit other training programs too. I'll be more than happy to answer any questions in the Q&A session. First, I'll discuss what drove us to rethink quality improvement and patient safety curricula. Second, the specific components of our curriculum here at Brown. And finally, I'll discuss adapting the curriculum to fit your training programs. You can find more details of our curriculum at brownpem.org. First, why we made this curriculum. For starters, since the To Err is Human report was released in 1999, the ACGME has moved to make quality improvement and patient safety training required for all trainees in accredited programs, though the language remains quite vague. More importantly, as emergency medicine providers, we see manifestations of poor healthcare quality every day. There's an increasing demand for transparency and accountability in healthcare. It's time for providers to be better equipped to fix the system. We have created a rigorous curriculum tailored for fellows interested in QI that aims higher than ACGME box checking and is adaptable to other residency and fellowship programs. We want to set trainees up for success with expertise and leadership skills in this emerging field. We aimed to avoid the dry content of many QI curricula. We found that focusing on terms like fishbone diagrams, champion, teamwork, brainstorming detract from the complexity of the field. QI is now a huge institutional and national concern and needs to be discussed in those terms. We also find the annual QI curricula trainees endure to be redundant. Annual discussions of PDSA cycles always remind me of history class in school. Each year we'd make it to the end of the Revolutionary War and immediately start over the following fall. There are four main pillars or components of our curriculum: formal instruction, committee involvement, teaching, and scholarship. These have each been woven into a longitudinal curriculum and a QI project devised by the trainee that takes place over the course of the 3-year program. We divided the content into 3 parts to fit the timeline of our training program. We place significant emphasis on first understanding the US healthcare system as a whole, and then making sense of our local hospital QI structure and completing a project. We have created a guide and lecture and independent learning format that discusses how our healthcare system works and relates to QI and what pay for performance and performance metrics means specifically for emergency medicine providers. We've selected certain IHI open school modules that we feel are most informative at this point in training. We've also created a growing QI article library for fellows to read from each month and to contribute articles of interest to the library as they go along. During second year, trainees are working on a QI project they devised during first year. They also choose from a list of additional educational options ranging from coursework at the School of Public Health to QI certifications and courses inside and outside our institution. Trainees are also expected to join our departmental quality improvement and patient safety committee and are welcome to join other hospital-wide and national committees. This allows for fellows to identify mentors from within a pool of quality improvement enthusiasts. Fellows are also responsible for giving relevant departmental lectures to fellows, faculty, and staff, lectures to other trainees and students who rotate through the emergency department, and helping to lead our morbidity and mortality conference series. In addition to finishing any training or coursework, the bulk of the third year is spent working on the pièce de résistance. We know it can be challenging to publish in QI, and we have resources and mentorship in place to transform the scholarly product into an abstract submission and/or publication. These resources include a list of journals and conferences that publish QI scholarship. The article bank essentially provides examples of successful QI manuscripts. We've identified mentors within the department to help with submissions and have access to our data analysts as needed. We devised a rigorous curriculum that fits the needs and level of training of pediatric fellows in our program at Brown who want to be leaders in QI in their careers. That said, it is certainly possible to tailor the curriculum's framework to make a robust QI experience in other settings. You too can think about what formal instruction, committee involvement, teaching, scholarship might look like at your training program. It's important to think about modifying this curriculum, which is meant for QI enthusiasts, to be a well-designed curriculum for those who merely need to be QI literate. We actually modified the enthusiast track to create a required QI track for the rest of our fellows. They still learn about the healthcare system as a whole, and then are expected to do some self-directed learning and to participate in a longitudinal group QI project with faculty mentorship. In summary, we feel we've made an engaging curriculum that maintains the rigor of any other medical discipline, encourages experiential learning and scholarly productivity, and hopefully helps create physician leaders in this critically important aspect of healthcare. By delving into the complexity of healthcare quality in our nation and daring to progress past rehashing my metaphorical Revolutionary War in our curriculum, we sincerely hope we've turned trainee groans into trainee gusto. You can find more details of our curriculum at brownpem.org. Thank you.
Good morning. My name is Kristen Ng. I am a simulation fellow in the Department of Emergency Medicine at Stanford University, and this is your brain on games. I have no disclosures to report today. Let's start by playing a game. I want you to pick one. Are you ready? Rock, paper, scissors, shoot. Which one did you choose? Did you win? Do you want to play again? What's going on in your brain right now that's making you want to play again? On a neurotransmitter level, games are meant to be addictive. Dopamine is released in the anticipation of receiving an award or reward. This is part of a cognitive process called incentive salience, which motivates someone towards something. It's also thought to play a role in forming associations between an action and its consequences. Sounds a lot like learning. The presence of dopamine creates a higher motivational state, which fuels engagement and primes neurons for neurogenesis and an increase in synaptic plasticity. Motivation begets engagement, begets learning, and we can understand why medical educators would want to harness this power. Enter the serious game. What's a serious game? It's a game designed for a primary purpose other than pure entertainment, and they've been growing in popularity in the med-ed world, especially during the pandemic when in-person learning's been restricted. However, serious games are costly to create, and they aren't always the most effective method. We mistakenly think that just because we make a game that people will want to play the game. Games aren't always the answer, but game design elements are a different story. Enter gamification. This is the process of taking something that already exists and using gaming design strategies to motivate and engage. Today, I will discuss 5 elements of gamification that you can bring to your existing teaching activities. Number 1, convergence of intrinsic and extrinsic motivations. When learners are intrinsically motivated, they do something because it's inherently interesting or enjoyable. When they're extrinsically motivated, they do something because it leads to a specific desirable outcome. Successful gamification combines these two motivations. Self-determination theory states that we're intrinsically motivated by the need for competence and autonomy. Learning activities that provide opportunities to acquire new skills use competence as an intrinsic motivator. In med-ed practice, this looks like focusing learning activities on the acquisition of meaningful skills. One example is aligning a simulation case to the intended specialty of a learner to maximize intrinsic motivation while still utilizing the extrinsic motivation of validation or reinforcement. Number 2, progress mechanics and feedback. Progress mechanics allow a learner to see the progress they've made with their learning and earn rewards as they progress. Immediate rewards strengthen learning and encourage engagement with learning processes at a neurobiological level. A key motivator of human behavior is a need to know how well we're doing, with the prospect of success being vital to increasing motivation and effort. Gamification literature states that feedback should be frequent and immediate or with shortened cycles to maximize engagement. Consider adding elements that signal leveling up to learners. This can look like badges, leaderboards, progress bars, or other benefits. In this way, the progress mechanics serve as feedback and intermittent extrinsic rewards. This also makes a case for rapid cycle deliberate practice. Number 3, narrative structure. Games immerse learners in the synthesis of narrative elements. Players take actions and then see and respond to their consequences, connecting cause and effect in a meaningful way. In med-ed, this can look like utilizing storytelling as much as possible. Anchor content to patient cases instead of solely presenting information. Consider inviting learners to drive the narrative of the case through their own clinical decisions, thereby immersing them in the creation of narrative elements. Number 4, experiential learning. Experiential learning entails having an experience and reflecting on it, or watching someone else have an experience and reflecting on it. Games offer experiences that players must rapidly reflect upon in order to determine their next actions. For example, instead of asking questions to solicit recall of content, incorporate role play and the creation of experiences in which the application of content knowledge is elicited. Offer a simulated experience that can be reflected upon to produce learning. Number 5, repetition. Repetition fuels the addictive elements of gamification by activating the reward and reinforcement neural pathways. It allows learners to consolidate knowledge. Furthermore, testing is more efficient than repeated presentation of facts. Today I've discussed 5 gamification strategies you can add to your existing teaching activities: convergence of intrinsic and extrinsic motivations, progress mechanics and feedback, narrative structure, experiential learning, and repetition. My hope is that you can appreciate how these strategies already exist within your pedagogical practice and lean into them further. Thank you for your time and attention. I look forward to your questions and your rematch requests. My name is Kristen. I am a simulation fellow in the Stanford Department of Emergency Medicine, and I am honored to share with you today. I have no disclosures to report. The greatest negotiator I've ever met was my grandmother. I spent most of my childhood summers in Boston Chinatown, where she would take me shopping in the market. And I noticed that she never read price tags and instead jumped right into bargaining. To her, everything was negotiable. So it's no surprise that one of my favorite things to do while traveling is to go to local markets to put the skills I learned from my grandmother to good use. But things were a little bit different when I became a new faculty member. I told you that I love to negotiate and bargain. But in my new role, I found it difficult to navigate the academic waters and take control of my time. I felt self-conscious, unsure of when to say no thank you or hello, pick me. I wanted to understand why I felt this way and what to do about it. I engaged in a lot of reflection and reading. I realized how much of my own apprehension was fueled by societal expectations of gender, and these effects trickled down and continue to affect our specialty in things like differences in median salaries and promotions. There's a lot of literature about specific strategies to use when negotiating, but I think that grazes over some important obstacles that women need to overcome before even getting to the negotiation table. Today I'm going to share 3 pearls that I've been meditating on. Number 1, ask more. Various business and psychology studies show that women do not ask at the same rate as men. At one business school, after noticing that salaries for male graduates were 7.6% higher than those of female graduates, researchers wondered why this difference existed. When they asked grads whether they attempted to negotiate a higher salary, only 7% of women said they had, compared to 57% of the men. We've seen that even when women and men negotiate at the same rate, there remains a difference, and we can start to reduce this gap by taking chances to ask. Women tend to pass up less obvious opportunities to negotiate. In the 2006 U.S. Open, women challenged 28 calls compared to 73 by men. Even the most highly skilled female professional tennis players are less willing to ask. This isn't just a deficiency that women need to wake up and fix, that simply asking for things more often will make years of wage disparities go away, but I think it's important to understand the forces at play that have led us to feel like it's not as acceptable for women to ask for things. What are some of these forces? Asking often entails a high social risk, as the directness involved appears unfeminine and women are more likely to be perceived as too demanding or too pushy. Women still perform the vast majority of unpaid labor in the economy, which brings us up to think that we work more for love and not money. To fight this, I've been taking mind to ask more, to talk back to the voice in my head that tells me to put my head down and wait for someone to notice. It means being audacious about my goals despite a fear of seeming demanding. Ask more. My next pearl is to expect more, and I mean this in 2 ways. The first is to expect that more is negotiable. Allow yourself to believe that everything is negotiable. And the second is to raise your standards about what's possible in the negotiation, because this will help you perform better. Women often expect to get less in their negotiations. Many scholars believe that women have learned to expect less in order to minimize disappointment and increase satisfaction, and that this is an adaptation to the way that the workforce has disenfranchised women for so long. Priming ourselves to expect more also helps fight stereotype threat, in which people feel themselves to be at risk of conforming to negative stereotypes about their social group. This uses up cognitive capacity and leads people to perform worse at a task like negotiation. Pearl number 3 is to prepare more. This is important for negotiation no matter who you are. It means taking time to know what you want and why, and think through acceptable alternatives. This helps you figure out if it's worth it to negotiate and to structure your research in preparation. This is because ambiguity negatively impacts negotiation performance, especially for women. A meta-analysis revealed that gender differences favoring men were reduced when negotiators received information about the bargaining range. Read, research, and get concrete numbers because this matters. And then practice with someone you trust. Find a community of trusted sounding boards, people who will toot your horn to you and to whom you can toot your own horn. Find people who will affirm your right to ask and give you safe feedback about potential blind spots in your preparation. Helping each other self-advocate is where women can excel. Women especially perform better when negotiating on behalf of others than for themselves. And one study showed that female executives negotiating for someone else secured compensation that was 18% higher. Today I've shared 3 ways to fight against gender bias in negotiation before getting to the table. Ask more, expect more, and prepare more. I invite you to take a moment to think about which of these you struggle with the most and commit to doing this more in the upcoming year. I know I will, especially as I graduate next year and head out into the job market. And you can be sure I'll be channeling the greatest negotiator throughout all of it, this lady right here, my grandma. Thank you for your time and attention, and I look forward to your questions.
I'm Dr. Tom Grawey, and this is using the skills of a resuscitationist to improve bedside teaching. In addition to the demands of being I'm Dr. Tom Grawey, and this is using the skills of a resuscitationist to improve bedside teaching. In addition to the demands of being an ED physician, many of us are consistently offered the added responsibility of teaching learners while on shift. Even though I strive to be an educator at all times, some days the other demands of this job make this particularly challenging. In the ED, as the number of sick patients increases, the amount of potential learning opportunities also goes up. Unfortunately, there is a point where my ability to teach and the learner's cognitive ability to learn starts to max out. The cognitive load of a busy emergency department can start to negatively impact performance and learning. Even if a teaching point is shared with the learner, the retention is often poor due to a decreased mental capacity to process the information into memory and retain it for later use. There are 3 big hurdles with on-shift teaching. Often patient care must take the priority, and the sheer volume of work makes finding time difficult to teach. Finally, when time is found, the learner may not have the cognitive space available to retain new knowledge. While crafting a solution, I saw the similarities between educating and running a resuscitation and the issues with priorities, time, and limited cognitive space. I came to discover that teaching on shift is no different than running an 8-hour-long resuscitation where the goal is to resuscitate the learner. Once I reframed bedside teaching to learner resuscitation, I began to approach the problem like I would a critically ill patient. I asked questions like, how can I organize my team around the common goal? How can I cognitively offload education, and what learning can be done now versus later? And this took shape in a cognitive tool that facilitates on-shift teaching, an educational checklist of sorts. By using the tool, I'm able to consistently provide the same level for teaching for the crashing learner on each shift, and even given the option to provide it asynchronously after the learner's left for the day. The tool is shaped similar to a resuscitation with 3 distinct time periods that contain different goals and responsibilities. Not only does the tool drive the contents of each phase, it serves as a reminder to complete the task in situations where patient care may pull you away from teaching. A pre-brief in learner resuscitation includes everyone on the learning team huddling together to discuss roles and responsibilities for the day. Outside of the logistics, we each discuss shift goals by answering the question, what do you want feedback on or help with today? This sets the frame by which we can help each other learn over the next 8 hours. Similar to how I look extra closely for hyperkalemia and the EKG in the patient who missed dialysis, myself and the other educational team members need to know what to watch out for in each other. The patient care section is the crux of the feedback tool. For each patient we encounter, teaching points are highlighted, and when applicable, online resources for further learning are provided. And while this may seem overwhelming, teaching points can be brief and not everything has an accompanying resource. This is most helpful when the ER gets very busy. Perhaps I had a good point on chest pain, but got pulled away. The form helps me to circle back later once things have calmed down, to jot down notes or resources for the learner to take home and study later at a more comfortable time for them. Debriefing after resuscitation is how we identify personal and system improvement goals to do better for our future patients. Educational team end of shift debriefs are no different, serving as an opportunity to come together at the end of a busy day in the emergency department. A structured debrief process helps combat the lack of desire to reflect when exhausted at the end of a busy day. I do my debrief at hour 7 of my 8-hour shift, since people aren't as focused on getting out the door when there's another 60 minutes left to work in the day. As I mentioned before, an overwhelming shift full of significant pathology can have low yield learning due to the lack of time and cognitive load of the learner. The most valued piece of this teaching tool is the email function, allowing the PDF to be sent to the learner after a shift to review at home. This allows for learners to reflect and learn from the shift at a time when their cognitive space is free and they're able to retain knowledge. The tool allows for pathology encountered on shift to be studied more thoroughly in a learning environment of the learner's choosing. It's time to update our on-shift teaching in a way that embraces the challenges of working in the modern emergency department. While learning on shift will always continue, we can work better to facilitate study time away from the department, highlighting pearls encountered critically on shift. By gathering our learning team around a cognitive tool that facilitates a pre-brief huddle, patient care learning pearls, and a debrief, the critically ill learner is to be well resuscitated with knowledge from a recent stressful shift in the emergency department. Finally, the volume, acuity, and demands of the emergency department can make it a difficult place to optimally learn and retain knowledge. But we can develop tools that not only facilitate on-shift learning, but provide a customized educational menu that learners can choose from to snack on later. On your next shift, take advantage of what you do best, being an expert resuscitationist, and use these skills to resuscitate the learners in your emergency department. Thank you.
Hi, my name is Ashley Voroba, and I'll be presenting today Simple and Sensitive, Ocular Ultrasound for Retinal Detachment, Posterior Vitreous Detachment, and Vitreous Hemorrhage. I have no disclosures. Your next patient to be seen in chairs is a 61-year-old male with hypertension and hyperlipidemia, complaining of painless unilateral visual changes that he describes as flashing lights, floaters, cobwebs, and a curtain coming down. To figure out what's going on with this guy, we're going to do a good history and exam. We're going to check his visual acuity, his intraocular pressure. We're going to use the slit lamp to look at the anterior chamber, and maybe even the ophthalmoscope to look at the posterior chamber, and at least consider neuroimaging. Assuming we've ruled out badness, we're left with this differential for painless unilateral vision loss, and we're going to focus on retinal detachment, posterior vitreous detachment, and vitreous hemorrhage, and specifically how ultrasound can help us make the diagnosis. Numerous studies, including most recently this prospective multi-center study from 2019, have concluded that ultrasound is both sensitive and specific for diagnosing retinal detachment, posterior vitreous detachment, and vitreous hemorrhage. So let's get set up. We need the ultrasound machine, we need to get the patient supine or with the head of the bed slightly elevated, and since the eye is a superficial structure requiring high-resolution imaging, we'll be using the high-frequency linear array probe. We're going to adhere to the ALARA principles, which stands for as low as reasonably achievable, and utilize our ocular presets if available, minimize color and spectral Doppler, and limit the total duration of the exam. So we're going to place a tegaderm over the patient's closed eye, pile on a ton of gel, ideally cold, and gently place the linear probe over the patient's eye, bracing your hand on the zygomatic arch. We don't want any pressure on the eye. We're going to scan the eye in both transverse and sagittal planes, and we're trying to identify in the anatomy the vitreous body, the optic nerve, and the retina. These are the most important structures in the posterior chamber for the diagnoses that we're looking for. We're going to start our scan with the gain turned up to 100%, and we're going to instruct the patient to look left and right, or medial and lateral. This is going to help us to see mobile pathologies in the back of the eye, and you'll see how this is important in just a minute. Let's start with retinal detachment. The retina is attached posteriorly to the optic nerve. In retinal detachment, the retina detaches from the retinal epithelium. Ultrasound is 96.9% sensitive and 88% specific for making this diagnosis. On ultrasound, we're going to see a hyperechoic structure floating in the vitreous that attaches at the optic nerve. So you can see it creates this V shape, and you can see that at the back of the eye. Again, here you can see the hyperechoic structure that's attached at the optic nerve that's in the posterior chamber. And in this scan, you can actually also see at the end a lens dislocation. This was a Marfan's patient. Let's move on to posterior vitreous detachment. The vitreous is attached to the retina. When it detaches, It's just flowing freely in the posterior chamber, not attached at the optic nerve. Ultrasound's not as sensitive, but very specific for this pathology. Here you can see a hyperechoic structure floating within the vitreous, and it's not attached at the optic nerve. We refer to this as the swaying seaweed sign, and this is consistent with posterior vitreous detachment. Here's another clip. Again, you can see a hyperechoic structure floating within the vitreous that's not attached at the optic nerve. That's the key in how you differentiate a posterior vitreous detachment from a retinal detachment. Finally, let's discuss vitreous hemorrhage. Vitreous hemorrhage is when you have blood inside or around the vitreous, and ultrasound is very sensitive and specific for making this diagnosis, 81% and 82% respectively. Here we see hyperechoic material moving back and forth as the patient looks left and right with those oculokinetics. We call this the washing machine sign. If you can kind of envision it, looks like soapy water going back and forth. In this clip, again, we have hyperechoic material within the vitreous that moves back and forth with the movements of the eye. And if you look closely, you can see also at the back of the eye, we also have a small posterior vitreal detachment. In summary, for your next patient who presents with unilateral painless vision loss, who you're considering retinal detachment, posterior vitreous detachment, or vitreous hemorrhage, first rule out badness, then grab your ultrasound. You're going to be great making this diagnosis. Thanks so much.
Hi, everyone. My name is Max Berger, and I'm currently a Medical Education and Simulation Fellow at UCLA Ronald Reagan Allevue after completing my residency last year at NYU Bellevue. And I'm going to talk today about what I learned as a patient in my own ED. To set some context, I've been a patient in the ED exactly twice in my life. The first was this time in college when I broke my nose getting hit in the face with a fastball. Luckily, the only lasting effects from this were some mouth breathing and a pretty entertaining YouTube video. And this is from the second time, during my PGY3 year of residency, when I developed right arm numbness shortly before my 11 a.m. Bellevue shift, and my attending thought it was probably a better idea to call a stroke code on me than to let me start my shift. I was diagnosed by my good friend and co-resident with a small acute ischemic stroke. They later found the PFO that was the likely cause. I had a procedure to close it several months later and have remained asymptomatic ever since. But the first couple hours in the ED and subsequent workup were some of the scariest times in my life in terms of what ifs. Looking back, I'm very thankful for what the experience has taught me about being a patient, and I think the experience has certainly made me a better doctor. Now, I don't pretend to be the only physician who's gone through a similar or worse experience with being a patient, but I hope by sharing my experience, I can inspire you to think about what our patients go through every single day when they come to the ED, and how we can hopefully make that experience just a little bit better. Having the advantage of knowing everyone in the department and it being a relatively slow morning, everything moved pretty fast for me. I was at CT within 5 minutes and sitting in the MRI machine within 20, which is probably a Bellevue record, yet it still felt like everything was taking forever. And literature backs this up. A 1996 study from Thompson et al. Looked at patient perceived ED length of stay versus actual length of stay, and only a third of patients were accurately able to estimate how long they'd been in the ED, with a significant portion overestimating that. So what can we do to help with this? We can't fix wait times, but we can try to check in with our patients more, let them know about delays, and especially at change of shift, try to let them know that you're leaving and a new doc will be coming by to update them soon. Now, I had the benefit of everyone believing exactly what I was saying, especially since I could explain it in medical terms. But I was young and healthy with isolated right arm numbness that was improving in the ED. How many times had I ignored a similar complaint thinking there's no way this could be something serious? But we need to be able to trust our patients. Would I have been taken as seriously if I wasn't a doctor? Maybe not. We owe all our patients this trust. This doesn't mean we need to do unnecessary workups, but we can at least pause to see if we have a bias affecting our decision-making. It's cliche to say that we take care of patients on the worst day of their life, but I'm a right-handed ER physician who suddenly lost function in my right arm. It got better, but what if it hadn't? Would I ever be able to work again? It's our job to ease some of that worry, and I think we can be really good at it. It might not be the high acuity procedure that we associate more readily with our specialty, but taking the extra 2 minutes to sit down and explain a scary diagnosis or provide reassurance can be even more meaningful. After discharge, I suddenly needed a PMD, a hematologist, a cardiologist, and a neurologist. I called offices and was told next appointment in 3 months. We often discharge patients and say, you should see a cardiologist next week, but can this actually happen? Study by Wang et al. In 2015 looked at ED follow-up within 30 days of ED discharge for chest pain. Only 69% of them were able to follow up with a PCP and only 17% with a cardiologist. This emphasizes to me that see your doctor in a few days is not good enough. So what can we do? Whenever possible, try to spend a little bit more time helping coordinate outpatient care, whether that's giving them specific names of specialists or closing the loop with their PCP via phone or EMR chat. And lastly, it's hard for our patients to process all the information we tell them, whether it's good news, bad news, or somewhere in between. I had 60+ advocates within my residency making sure I understood everything and paying attention when I couldn't. But 99% of our patients don't have that. So as much as I can, I've started to try to check in with my patients' families as well, and not have the patient be the only person that hears the results or the plan. This can go a long way in ensuring patients understand what we did for them and the plan going forward. So what did I learn as a patient in my ED? Check in often, trust our patients, sit down for a couple minutes with them, try to coordinate outpatient care, and find and be your patient's advocate. I want to thank you all so much for listening, and thank you to my entire residency family for getting me through what was one of the hardest times of my life. And here we are celebrating residency graduation in Central Park after making it through the pandemic spring in New York City.
Hi, everybody. My name is Dr. Patricia Newhan. I'm the program director at Ascension St. John Hospital in Detroit, Michigan. And my Ignite presentation is, will post-COVID interviews remain virtual? Now, our interview season perspective is very different right now. We had to adapt to reliable platforms to interview virtually. And the two main questions are, will we choose to replicate it? And was it personal enough? Now, what does the literature say? Really, there are no statistics. It's mostly descriptive literature in Nature on business and medical fellowships, but never in such high numbers as we did this year. I did an internal 8-year quality project asking candidates, would you match a program with just a virtual interview? 8 years ago, 32%. 7 years ago, 65%. This year, it was a mandatory 100%. Now, medical education and programs, as well as candidates, have the same target. We want a low-cost, high-value situation to get noticed and recruit for the best fit. The flexibility is very important. We had flexibility with scheduling. Did we have group or single interviews? We even just had to wear a suit jacket and have maybe pajama bottoms since we were on screen. Time was very different. We didn't have to drive into work. We could make schedule changes easily if there was a cancellation, and we could accommodate different time zones for candidates. Now, virtual interviews save on travel time and money for candidates. There was a rough estimate with one of my internal projects that the average candidate spent $6,000 for travel and application fees, and it's greener to not travel by plane. The convenience is significant. We could start our interviews earlier or later. We could perform them at home rather than all at work. The real issues that we had were the technical difficulties. Maybe the audio was bad. We would have screen freeze. The group chats were difficult with talking simultaneously, and the communication was just less spontaneous with groups. It was not quite the same. You know, when you're seeing the ocean, you know, hearing it and seeing and feeling the sun on a sunset, it's just different than seeing a photo or a video. Now, tours of the department were static too. Now, you can have a video, but it's still not quite the same. You don't get a sense of the physical space when you're trying to give a candidate a tour. The meet and greets with the residents were different too. You know, you might have some personal interactions that are hard to replicate virtually. Videos are helpful, but it's, again, just not the same. What's very important, we found out, is that social media presence is important. Having an Instagram, Facebook page, interesting website are key to attracting candidates, especially with virtual interviews. Being creative in that virtual outlet is very important as well. Live stream events were great. Chats with the faculty, having resident testimonials were all creative ways to increase that social media presence. Now, I think the interview season showed us that virtual interviews can be used as a screening tool. We'll have a hybrid approach with brief initial screening virtual interviews before in-person interviews. You can have groups of interviewers or faculty discussing unique aspects of the program using a virtual platform. Now, how do you make it more personal? You want to reach out in multiple ways, both virtually and in person. You want to make the virtual interactions interesting, but genuine simultaneously. And that's the difficulty with the virtual technique. What is the best combination? A hybrid. You want the convenience of an initial virtual interview and then bring those candidates in for tours, interviews, social gatherings, if possible. Will post-COVID interviews be virtually? I think partially because of the great cost savings, but the in-person interaction is key. The best of both worlds is the hybrid format. Thank you for your attention.
Hello, I'm Jessie Nelson, core faculty at Regents Hospital in St. Paul, Minnesota. Thanks to SAEM for the opportunity to talk about a topic that some of us think a lot about, some ignore, and some actively avoid by sticking their heads in the sand: personal finance. I have no conflicts of interest. I'm not a financial advisor, let alone your financial advisor. I have no blog and no affiliated links. I'm not writing a book. I have nothing to sell. Some of you have met your financial goals. That probably wasn't an accident. You likely made plans and took action. Or are you one of those people who are actively avoiding your money situation or ignoring it? Do work with someone who is. This talk is for you. Why do we avoid it? It's complicated. Yeah, the financial industry makes sure that finance is complicated, but the idea that you can't learn it, I don't buy that. You are learning or practicing medicine. You can do this. Maybe you don't have time. That's fair. You have a lot of stuff on your plate, but that's not going to get better anytime soon. Some say I don't have time means it's not a priority, but most of them haven't been residents. Maybe you don't know where to start. That's a fair point. You have a lot on your plate. The lack of information is not the issue. It's actually you're drowning in too much information. Some of it's really good, some of it's totally irrelevant, and some of it is kind of sketchy. Perhaps the issue is deeper. Societal taboos restrict how we talk about money. And when we say we're avoiding money, I suspect we might be ignoring other things. You know that ostriches don't actually bury their heads in the sand? As camouflage from predators, they lay their head down on the sand in order to look like a rock from the distance. Now, ostriches are hiding from lions, but what are we hiding from? Fear, shame, regret, vulnerability, hopelessness, isolation. Despite that discomfort, we should face this. Why? For our wellness. More debt correlates with more stress. While it's hard to eliminate the debt, clarity and a plan can lighten the cognitive load. Another former president known for his eloquence sums up the main reason I think you should learn about money. It's your money. They call it personal finance for a reason. So now you want to do something. What do you do? I think the first step is to understand and manage your thoughts. How you think about money affects how you feel about money, and that changes your actions. Focus your thinking on that intersection between the things that matter and the things that you can actually control. And look at reality. Do you actually know how much debt you're in or how much you've saved? I didn't until I took the time and figured it out. If you're not sure where you are, sit down and think about it and then take a guess and write that guess down. Then look at the reality. Find your paperwork, access your accounts, and document the reality. Is that reality better or worse than you expect? Even if it's worse, you're better off knowing the reality. After all, you can't figure out how to get where you're going if you don't know where you are. And once you figure out where you are, then you can plan your next steps. Where are your knowledge gaps? The information is out there. Once you start looking for it, you will see it everywhere. Warning, it is a bit of a rabbit hole. As of March, there are at least 823 active personal finance blogs, mostly written by lay people who just want to share their lessons that they've learned. Now, if you don't like what one of them is saying, fine. There are at least 822 other ones out there. With a little work, you will find your people. Students, a career in medicine is a long journey. There are pitfalls, there are potholes, there are detours. The terrain is uneven and definitely not fair. Nothing's guaranteed. But your choices made early on will affect your options later in life, so choose wisely. Residency is stressful, but it's fleeting. During these limited times, stick to a budget and stop the cash hemorrhage. This may be the first time you have a job with legit benefits. Get to know them. And faculty, we need to talk. We are the keepers of perspective. We've been there, but we need to understand that where they are right now is not the same place we were back then. Empathize, listen, and help when you can. Normalize talking about personal finance. And use work that's already been done. You don't need to be an expert. You're just another person who sort of gets where they are, and that's good enough. After all, we do more than teach emergency medicine. We build successful emergency physicians. So even if you think it's too early, too late, too hard, or too scary, you can do this. Lift up your head, look around, find your bearings, and start walking one foot in front of the other. Then share what you learned with the rest of us. Thank you.
From survey studies, we've learned that about 1% of youth identify as transgender, with the mean age 13 years. These youth face family rejection and psychological distress, and while the ED healthcare needs may have nothing to do with gender identity, fear of discrimination, being outed, or safety concerns may be significant barriers to care. Gender identity is a person's internal, deeply felt sense of being male, female, or something other. Gender expression is external in contrast to gender identity. Transgender means that gender identity differs from the sex assigned at birth. Gender affirmation can occur socially, legally, medically, and rarely surgically. Affirming is supporting gender identity. Misgendering is use of incorrect name or pronouns. The 6 H's is a way of organizing your approach to care of the transgender teen in the emergency department, and it includes hellos, HPI, heads assessment, help, head, and healing. Hellos is the first opportunity we have to let the teen know that gender identity is respected and normalized. Hi, I'm Dr. Carroll. I see from the chart you use the name Alex. What pronouns do you use? Note that I didn't ask for preferred pronouns. Your patient is not saying what I prefer, but is saying this is who I am. If we do misgender, let's apologize and move on. The HPI is the opportunity to take a seat, use open-ended questions, and don't interrupt. Listening accomplishes so much, but most important, building trust between the teen and the clinician. HEADS assessment has been referred to as review of systems for the adolescent patient. This gives context, including home life, education, activities, drug use, sexuality, suicidality, and safety. Is the patient getting help? Maybe in the form of subspecialty care, maybe in the form of gender-affirming hormone therapy. But we as a provider need help as well. We may need to confer with those specialists. We may need a chaperone, particularly during the breast and genital exam. The child may be getting help from gender support garments, and the chaperone is key in making this part of the exam comfortable for the child. We head off any privacy issues. We want to know what's been disclosed to the parents so that the child is safe with any disclosure in the ED. And we head into medical decision making with a robust diagnostic differential. To proceed with healing, answering all questions, coming up with a plan of care, and important referrals. Any information that the parent may need can be found at a variety of sites, including PFLAG, WPATH, as well as the American Academy of Pediatrics. Let's use the 6 H's with a case of 17-year-old transgender male who presents with repeated vomiting, subsequent epigastric pain. We start with hello, set the tone, we know his name and preferred pronouns, and request that mom step out of the room during the exam. The HPI allows us to sit privately and start with the patient and start listening. He tells us about his bouts of vomiting that have happened in the past. We learn about no associated symptoms and no COVID exposures. The HEADS assessment includes finding out that he lives with his mother and his teen sister, that he goes to school, he has a part-time job, he smokes pot to help alleviate anxiety, he is no longer sexually active, and is not suicidal. The patient's getting help in the form of an endocrinologist who prescribes testosterone therapy and a psychiatrist prescribing an SSRI. We need help in the form of a chaperone who assists in removing a chest binder so we can examine the upper abdomen, and we contact his endocrinologist. We're going to head into a diagnostic differential, remembering that with female organs still in place, the child is at risk for ovarian pathology as well as pregnancy despite testosterone use. We're going to head off privacy issues. Mom may know about the POP and not the frequencies, the child ready to disclose with the support of the ER doc. We're going to proceed with healing. We're going to answer all questions, review data, open the conversation up to the parent with the child's permission, and provide important referrals. If the patient is not out to parents, we're going to avoid pronouns and instead say your child. If there's a new disclosure by a teen, let's thank the child for that trust and acknowledge with thank you as a supportive parent. When it's time to sign out, let's not make the patient go through explanations a second time around. Let the child know a provider is arriving, get permission to share identity, and sign out to your peer. The 6 H's really organize our skill set. This encounter has used all of our skills: respectful communication, maintaining patient dignity during the exam, understanding the pathophys of disease as well as treatment side effects, so that we complete a thorough evaluation and make an accurate diagnosis, all in a bias-free, compassionate, and gender-affirming environment. Let's empower our transgender teens to affirm their gender identity, to have fair access to care, to be regarded and treated as equals. The transgender teen is not a set of pronouns, but a complex person working to find and define self. Let's remember the words of Maya Angelou, who said, "People will forget what you said, people will forget what you did, but people will never forget how you made them feel."
Hello, my name's Madeline Grawey. I'm an emergency medicine resident at UCSF and director of research of ODR. Today, I'll be talking about our work helping patients vote like their health depends on it. On a shift last summer at San Francisco General, our local safety net hospital, I took care of a middle-aged man presenting with leg pain. Physical exam demonstrated a severe soft tissue infection, and laboratory workup revealed he was in DKA. On review of his chart, I saw he'd already been to the ED earlier that week and was prescribed antibiotics, but he had not filled a prescription and his infection had worsened. He also hadn't been using his insulin for his diabetes. As we spoke, I learned that due to the pandemic, he lost his job and income, and then his housing. He was no longer insured through his employer. In order to save money to feed his family, he'd only been taking his medications sporadically. In emergency medicine, we see countless patients like this one, for whom upstream social policies can significantly impact their downstream determinants of health. In the civic process, individuals have the power to express support or dissent for these policies. Those who participate are more likely to see policies that represent their interests. To put it simply, your vote impacts your health. Unfortunately, 1 in 4 eligible voters is unregistered, including my patient. When I asked him if he had a plan to vote in last year's election, he told me that he had bigger problems to worry about, like putting a roof over his head and food on his plate. Plus, he felt like policymakers didn't care about him. He happened to be Black, with low income, and without a college education. He belonged to 3 groups who experienced disproportionate underrepresentation in the civic process, in part due to social barriers and in part due to active voter suppression. We interact every day with patients belonging to these groups. Why, when we complete our social histories and assess their social needs, are we not addressing their civic health? This key demographic overlap presents an opportunity for us to elevate the voices most marginalized by our current system. This is the motivation behind VoteER, a nonpartisan nonprofit started by Alistair Martin at Mass General. Our goal is to promote civic health and voter readiness in healthcare spaces, and we do it in 3 main ways. First, we equip individual healthcare workers with Healthy Democracy kits. These are plastic badge backers that fit right next to your hospital ID. The QR and text codes take patients to a mobile platform and to check their status, register to vote, or vote by mail. Emergency physicians are the 3rd largest group of kit users. Over 1,200 of you, including many in this audience, have these kits and use them on a daily basis. In addition, several of your hospitals and EDs have equipped your entire staff with badges, bringing us to our next method, site-based setup. To the left is a digital kiosk in the Einstein ED waiting room before COVID, and to the right is a poster in Spanish. Hospitals, clinics, and now vaccination sites display these so patients can register themselves while waiting. Customizable codes allow sites to track their local impact. This technology opens the door to our 3rd main approach, cross-institution collaboration. We hosted a friendly competition amongst 80 medical schools, leveraging gamification and rivalries to prepare more than 15,000 people for the 2020 elections. In addition to making a positive impact on their communities, almost every single student surveyed believed that civic health should be a component of formal medical curricula, and they planned on incorporating voter registration into their future practice. These students are not alone in wanting to spur cultural change. Over 100 healthcare and civic engagement organizations, including EMRA, joined forces for the inaugural Civic Health Month last August, together promoting the importance of equal access to civic participation. The swell of support across geographies and contexts was particularly poignant amid the backdrop of 2020, as our country grappled ever more fiercely with systemic racism. The desire to address social and racial inequities was the most common primary motivation for VOTR participation. This movement did not only involve physicians and med students, but dozens of other healthcare roles, including nurses, PAs, social workers, techs, therapists, interpreters, and hospital leadership and administrative staff. During the 2020 election season, we deployed our tools across hundreds of hospitals and clinics, mailed more than 24,000 kits to providers in all 50 states, and in total helped more than 46,000 people register to vote and request mail-in ballots. One of these people was my patient at the General. We admitted him for IV antibiotics and insulin, sent him up for emergency Medicaid, and I used my VOTR badge to direct him to the online voter registration portal so that in 2020, his voice would count. The 2020 election had the highest turnout of any in history, but our work does not stop there. We will continue to advocate for the civic health of our communities in future local and national elections. If you haven't yet, join us. As Virchow, the hipster of social medicine, advocated more than 150 years ago, we must address structural determinants of health in order to meaningfully improve the health of our communities. This starts with voting. Our patients' health depends on it.
The ED's dirty secret: how plastic waste generation and management is on all of us. I'm Anna Brandis, a 3rd-year medical student at the University of Utah School of Medicine. Our overall goal is to balance concerns for public health in terms of disease transmission with environmental sustainability in terms of waste management. It's very possible to do both. Let's talk about the facts. Emergency departments generate lots of waste. A recent study found that for one patient encounter in a level 1 trauma center, there was just shy of 2 kilograms of waste generated. Much of that is plastic. The push towards plastics in healthcare really took off during the AIDS epidemic. Plastic industries capitalized on the fears of infection risks sweeping across the country. Sterilization packets for surgical instruments and kits became popular during this time. Chemicals used in plastics such as DEHP and dioxin have been shown to contribute to neurocognitive decline and reduce reproductive capacity. Producing plastic is energy intensive. It produces greenhouse gases, and a lot of those greenhouse gases seep out into our environment. And greenhouse gases from the healthcare sector equate to 10% of the country's total emissions. But it doesn't end there. Where we choose to dispose of our waste really matters. In terms of medical waste versus solid waste versus recycling, Medical waste is the most energy intensive to dispose of. There are ways to mitigate this waste. Let's talk about them. It starts with smart purchasing. Many multi-use devices are often just as safe as single-use devices and make more sense for cost savings. Opt for choices with less packaging and for devices that avoid chemicals like PVC, dioxin, and phthalates. Use only what is needed for each patient. Review infection protocols. Look to guidelines from manufacturers, infection control in your local hospital, and National Society guidelines. What actually needs to be thrown away once a patient leaves? Here are some organizations that you should know about. Healthcare Without Harm is a network devoted to changing the healthcare sector worldwide. With global sectors, they host conferences, promote environmental health and justice, and provide various resources through their sustainable procurement program. Practice Green Health is a membership and network organization that supports hospitals and healthcare systems in their efforts to become more sustainable. They have a sustainable procurement database with resources to help hospital administrators make smarter purchasing decisions. The Healthcare Plastics Recycling Council is a national organization that aims to collaborate across the supply chain to provide safe and cost-effective recycling solutions to the medical waste. They employ circular economy and new plastics economy concepts. Ultimately, this is an opportunity to leave the planet healthier for future generations. Making good decisions for the Earth today will result in better health tomorrow. Waste generation is just one aspect of planetary health. We need to be thinking about this on a big scale to put things into perspective. The way we treat our planet will result in better health for everybody. Thank you for listening.
Hello everyone, and thanks to SAEM for having me today. I want to try to convince you that you should use a bougie for every emergent or urgent intubation that you do. I think it makes our lives easier and is the best thing to do for our patients. The only exception is when you're using a hyperangulated video laryngoscope, in which case you'd use a hyperangulated stylet. This talk applies to standard geometry, Mac or Miller laryngoscopes, video or direct, which I think are the superior devices in our setting. So you're intubating an otherwise healthy 32-year-old male for a polypharmacy overdose. He's well preoxygenated and hemodynamically stable. He looks like an easy intubation and you're not too worried. You give your drugs, but when you go to intubate, this is the view you get. You try to optimize using head elevation and ELM, but this is the best you can do. Your options here are A, to try to pass a styleted ET tube, which is not likely to be successful. B, pull out and try a different approach. Or C, use a bougie. The primary benefit of the bougie is that you can intubate with an epiglottis-only view as long as the epiglottis is lifted. The bougie can be passed underneath the epiglottis into the trachea. If you're in the right place, you'll typically be able to feel tracheal rings and confirm your placement. Here's a comparison of 3A versus 3B. 3B is epiglottis only as well, but it's not lifted. The patient on the right is likely impossible to intubate, and the view must be optimized by engaging the hyoepiglottic ligament to lift the epiglottis. Here's an example of a DL bougie intubation of a grade 3A view. You can see the bougie is passed just underneath the epiglottis. The operator feels tracheal rings as confirmation of placement, and then the tube can be passed over the bougie. For reference, a styleted ET tube can only be passed safely with at least a grade 2A or 2B view. Using a bougie greatly increases your ability to intubate a patient with a more restricted glottic exposure, potentially preventing the need to reoxygenate for another attempt. So you're probably asking, why can't I just use the bougie when I have a restricted view and use a styleted tube the rest of the time? To me, it's about having respect for the airway. We know that most difficult intubations are unanticipated, so using a bougie every time is part of preparing. The reason we have backup plans and extra equipment and checklists is to prepare for the worst. If we treat every airway as difficult from the beginning, we will be prepared when an airway is truly difficult. The bougie is an easy intervention to address unexpected difficulty. Now imagine you haven't used a bougie in months and you encounter an airway where you need it. Since you and your assistant aren't well versed with it, it takes some time to get it ready. The patient starts to desat, you have to reoxygenate, and now you're on your second attempt. But if you use the bougie all the time and include it in plan A, it would have been ready and you would have been able to grab it comfortably and secure the airway rapidly without having to delay the intubation. Increased familiarity leads to increased comfort. Consider also that routine bougie use increases first pass success. This has now been shown in multiple trials, and this is also not surprising if you recall the situation I just described, but also because anyone who uses the bougie regularly knows that it makes tube delivery easier. The BEAM trial, which is the largest study so far, showed first pass success of 98% with the bougie and 87% in the control group. The difference was even larger in patients with at least one difficult airway feature at 96 versus 82%. One of the best bougie features is the real-time feedback. It's essential because if we pass the bougie without being able to see the cords, we need to have an idea of if it's in the right spot. There are two primary methods that we can use to confirm bougie placement. The first is by feeling tracheal rings. The coude tip of the bougie will click as it passes over them. The tip must be pointing anteriorly to reliably feel clicks, as the rings are not present posteriorly. I personally have felt clicks in every patient I've intubated with the bougie. The other confirmation method is hold up, where you gently advance the bougie until it hits the carina or lodges in a main stem bronchi. If the bougie keeps going, you're in the esophagus. Hold up may be traumatic though, so I don't recommend it unless you're unsure. I want to finish with some bougie tips that will improve your success. First, the ET tube may lodge on the right cord. Rotating the tube 90 degrees counterclockwise realigns the bevel and allows it to pass through the cords easier. You can do this routinely as you advance the tube. Always leave the blade in and maintain your view as you advance the tube over the bougie. This is to make sure the bougie stays in place and the tube goes where it needs to. Also, if you remove the blade, the airway collapses in the bougie and makes it more difficult to pass your tube. The last tip is to hold the bougie however you're most comfortable and practice with it. I personally prefer to pass a naked bougie and then load the tube over it, but there are many preloading techniques that seem to be equally effective. It's more about personal preference and your comfort. I personally think a max-shaped video laryngoscope and a bougie is an unstoppable combination that should allow you to intubate almost anyone. I hope I've been able to convince you to use a bougie on every airway. You can scan the QR code for more information. Thanks again for listening.
As a very burned out resident a few years ago, I sat on a lecture from someone telling me how getting enough sleep and participating in rejuvenating personal activities like yoga were the key to feeling good on the job. As I pondered my sleep debt and my apparent acute on chronic yoga deficiency, I had my doubts. Would yoga help me derive more enjoyment from mollifying the angry patient who had been in our ED waiting room for 8 hours? Would it help me feel better about the care I was providing for the bipolar 8-year-old who had been waiting in an ED hallway for 2 days for a psychiatric placement? With about 50% of our emergency physicians burned out, I found it hard to believe that we're all really just that bad at organizing our personal lives and finding fulfilling things to do outside of work. In fact, in EM, I find that my colleagues are really pretty good at finding interesting things to do in their free time. Now, I will admit that COVID has made me realize I underappreciated the ability to play soccer with friends and then get a drink afterwards. There's no question that the pandemic's impact on our personal lives has taken a toll. But at the same time, I think we all realize that the key to surviving COVID has really been this. Do we have enough protective equipment to keep ourselves safe and our families safe? Do we have ventilators and the resources we need to take great care of patients despite a new and challenging disease? Surviving COVID as EM providers depends on being part of effective health systems, which are variable. COVID has made this more obvious than ever, but this has always been true. The nature of our workplaces and the broader health systems, the expectations we face during shifts, and the experience of taking care of patients in our EDs really determine whether or not we're going to become burned out. Christina Maslock and Michael Lader, across decades of research in various industries, found the same thing. While we focus on individual interventions, often in healthcare and other places, about 80% of burnout is actually explained by organizational factors. They found that there are 6 domains of organizations that determine whether or not people will be engaged and fulfilled at work or burned out. And these are workload, rewards, control, fairness, community, and value congruence. For us, workload is about how many shifts we work, how our shifts are scheduled, how much is our admin burden. And how many patients are we expected to see on a shift? In EM, we certainly don't like to be bored, but even for us, too much really can be too much. Rewards are about being paid fairly for our work, but also non-financial rewards. Do we find meaning in our work? Can we feel pride in the quality of care that we're able to give? And do we receive appreciation from our leaders, our colleagues, and our patients when we do good work? Can we practice emergency medicine in the ways that we think that we should? Or are we distracted by administrative tasks and activities that don't add value? When we see something wrong in our workplaces, are we able to do something about them and change it? Or do problems persist and make us feel powerless in our workplaces? Is the work and the credit allocated fairly in our groups? Are decisions by leaders made in a transparent way that we can understand? Or is there distrust in the process and decisions are made behind closed doors? Perceptions are just as important as reality, and transparent decisions are important for staff buy-in. You can survive a lot of hardship with people who care about you. Are the members of your ED a team who are excited to see each other and support each other when times are hard? Or is there a lot of blame and distrust? Building strong community is crucial for preventing burnout at any stage. And finally, value congruence means that your care environment allows you to fulfill the core values that you believe in as an emergency practitioner. The opposite is a workplace that forces you to compromise your values and doesn't allow you to provide the kind of care that you think that you should. We surveyed our faculty to ask what features of our COVID response were most important for their well-being. They said meaning and common purpose, community, strong leadership, open communication, operational improvements, and the institution's preparedness were the key factors. It is worth emphasizing that these are all structural components of our department. None of these are add-on features or quote-unquote wellness programs. The most important things for our physicians' well-being during COVID were the successes or failures in our core functions as an emergency department. Now, I don't want to minimize the importance of mental health resources or the benefits of personal practice like mindfulness. We have stigma in medicine about seeking out mental health care, and COVID has only emphasized how crucial it is that people who are struggling have access to resources. Caring for ourselves outside of work is crucial. But a counseling program is still not a plan for physician well-being. If we want to love our jobs and be fulfilled at work, I believe we have to focus our efforts on the workplace itself, consider the impact of operations, clinical resources, teamwork, and leadership on how we experience our work. We know that burnout hurts quality of care for patients, but the converse must also be true. If we can make our jobs more satisfying and fulfilling, that can be an incredibly potent way to improve the kind of care that we can provide for our patients in the emergency department. I do hope we can get back to our fulfilling activities outside of work after this pandemic. But if you want to hear more specific ideas about these 6 domains, we wrote about them in JSEP for general EM and COVID in the Harvard Business Review. And please feel free to email me at jbaugh@partners.org. Thank you.
Hi, I'm Ash Ryder, and I'm going to spend the next 5 minutes talking about the future of our specialty. I graduated from residency in 2019. Here's my class of outstanding doctors, smiley and thrilled for the future of a rewarding career. I'm no expert on this topic, just a concerned recent grad who's been through job search twice. As part of my fellowship this year, I interviewed more than 100 eager emergency physicians to be who will soon be those smiley grads. At the same time, I listened to their idealistic visions for the future. Many of our colleagues were struggling to find jobs. The EM landscape has drastically changed in 2021 and will likely continue to change. As this Washington Post article highlights, many graduates can't find jobs. How did we get here? 1979, the year EM was approved as a specialty. Growth ensues. EDs were in need of well-trained physicians, and EM was the second lowest for graduates not finding employment in all the House of Medicine. It was dreamy. Fast forward 20 years. 2 workforce studies from the late 90s reveal that we have 27,000 EPs in the country's 5,000 EDs. Overall, there was undersupply in several states. EPs were in need. Another decade goes by. Gindy et al. Publishes a workforce study based on the AMA physician master file, which of note does not include osteopathic physicians. They found that of the 39,000 active EPs, there's a dramatic mismatch in the rural compared to the urban areas. 10 more years. 2 publications in Annals by Nelson et al. And Hall et al. Painted a picture of a growing workforce that outpaced all other specialties. We added 20,000 EM clinicians, and about a quarter of them were APPs. Hear this. Between 2010 and 2018, the number of ABEM physicians increased by 4% per year.
Ryder et al. Described a 46% growth in residency programs over 5 years and warns of a potential oversupply by 2030. 2020 brought us 2 publications by Bennett et al. And Clay et al. The take-home point: growth does not equate to distribution, as 92% of EPs choose to work in urban areas. Rural areas are still in need. Then COVID happened. We are simultaneously essential workers and disposable due to low volumes. COVID is not responsible for our current job market, but it certainly accelerated the process. This is not an ACGME problem or a residency problem. This is an us problem. What do we collectively do? To start, our national EM organizations are hard at work. We all need to be fired up. I'll be honest, the answers are not straightforward, but every solution has to start somewhere. Let's entertain a few ideas while I still have 2 minutes of your time. First, we do not need more residencies. Rather, we need more exposure to rural practice settings. While rural residencies may seem like a solution, they may not have the volume or infrastructure to support a training program. Second, given the rapid changes in the workforce recently, we need to stay on top of the numbers. We need funded studies that incorporate APPs and non-ABM physicians and use this data to drive decisions. Third, it's the age-old supply and demand question. How can we modify our current residency structure to be cautious of the potential oversupply? While not popular, cover your ears, Jimmy folks, this may mean limiting class sizes or changing to a 4-year model down the line. Fourth, increase our demand. The growth of traditional EDs may not be on pace with the number of emergency physicians, but we have a versatile skill set. Practice settings may look different: telemedicine, freestanding EDs, and administration, among others. Finally, job fairs and Facebook groups are a fine place to start, but how can we better facilitate connections? Why is it so challenging to find out the staffing group for given ED or for graduates to connect with leadership? We can build a better network, one with transparency. We now have 239 programs in the US, graduating approximately 2,500 new EM physicians a year. For the sake of our future colleagues and all of the patients we hope they will care for, we have to begin strategizing. This is ultimately about people. Remember those faces? You're one of them at one point. Recall how hard you worked to match into EM and then train for a grueling 3 to 4 years. It was worth it, but we need to make sure it stays that way. Below the surface, emergency medicine is bleeding. I hope we can have some meaningful national dialogue to address this issue. Emergency physicians are resilient. We bring order to chaos in every single shift. We can do the same to maintain equilibrium in our specialty. Thank you.
Hello, and thank you everyone for joining me today. My name is Dan Frank, and I'm the Emergency Medicine Residency Program Director at South Shore University Hospital, part of the Northwell Health System in Bayshore, New York. I wanted to use the few minutes I have to introduce our program's experience in producing a video for this year's recruitment season. Many residency programs are already accustomed to utilizing various digital platforms to promote their programs and augment resident education. Twitter is often utilized to promote clinical concepts and disseminate evidence-based medicine. YouTube can help viewers master procedural techniques. Instagram provides insight into culture and camaraderie. And many programs host their own residency website full of information related to the program. But regarding videos specifically, while some programs have utilized them in the past, they have never appeared before to the extent we are seeing this year. GME has never previously embraced the video platform. Existing GME literature focuses on social media's use as an educational tool and for essentially conducting a background check of their applicants, but never specifically has it been used before for recruitment. This year, videos boomed. Our own health system, for example, saw 36 different videos produced this year to highlight the overall GME experience and spotlight specific programs and facilities. North Carolina and Vanderbilt universities created several impressive videos as well, and the list could go on and on. We believe that these promo or sizzle videos, as they're often called, are becoming an indispensable part of the burgeoning virtual recruitment environment. Like any commercial you've ever seen on TV, these videos are designed to combine visuals, audio, and messaging to create a quick, stylized overview of a product, service, or brand. So how can you get started developing your own video to highlight your residency's brand? My first suggestion would be, as program director or associate program director, take charge and don't delegate this one. No one is better equipped to understand all of the nuances of your program, how to decipher the main program highlights, and how to deliver the kind of message you want to your potential recruits. Next, hire professionals. Filming, lighting, sound, editing. Unless you are exceedingly talented and have weeks or months to devote solely to this project, you cannot do it on your own. There are many companies out there that do this kind of work, so start by seeing who your health system has used before for their own marketing projects. Then, once you decide on a firm, ask, how much is this going to cost? Expect to spend anywhere from $5,000 even up to $30,000 depending on the detail and quality you're looking for. While this may seem expensive, recall that money has been saved this year by canceling conference travel as well as canceling meals and social events for a traditional recruitment season, so this may not be too difficult to sell to your leadership. Next, work with your production company to establish a precise scope of work agreement to define exactly what the company's deliverables are, from film quality to voiceovers, editing, royalty-free music to be added. Will they provide the video in two formats, such as one for high-quality video streaming and one formatted for mobile devices and social media apps? What is their timeline? What is the payment schedule? These should all be explicitly laid out in a contract. Then move on to developing and planning the story you want to tell. What makes your program unique and sets you apart? Maybe it's your size, your location, patient population, or faculty. Then ask, who is best to deliver that message? There's not enough time to have everyone featured. Some parts should probably be delivered by your faculty or program leadership. I think most candidates want to know who they'll be working for, but certainly make sure to highlight your greatest resource, your current residents. Then start planning a shot list. You will need to have a precise schedule worked out ahead of time, detailing location, who's required from cast and crew, and what the goal of each shot is. These shots can and should happen in parallel to be as efficient as possible. For example, while you and a resident are being interviewed in one space, the crew should be filming shots for B-roll elsewhere. So what's B-roll? These are the secondary images that add a lot of character and flexibility to a shoot. They help establish a setting and cutaways from the primary speaker to provide visuals that help tell the story. In the lower right corner, you see me being interviewed and delivering information about our program. That's your A-roll. But the editing process will weave in these various other images you see while the narrator is speaking to help bolster the story. That's your B-roll. You will need a lot of B-roll. For every 3 minutes of video, you should expect to have approximately 30, even up to 50 different shots. The constant visual movement keeps your audience engaged, helps you cover up errors, and allows you to showcase more of your facility and resources. Next, aside from those people speaking in the video, write a script to provide additional narration to make any points you want that weren't covered by your video participants. Estimate 1 page of script for every 3 minutes of completed video. I would recommend having this scripted narration read by a professional voiceover actor. The shift in voice and change in sound prevents a monotone feel and keeps your audience engaged from an audio standpoint. Once the editing process is complete, think about dissemination. I would recommend hosting your video on a pay-for-service site like Vimeo or something similar. This provides a lot of analytics. How many times has your video been viewed? Is it being viewed on desktops or mobile devices? Where are your viewers primarily located? And how are they finding you? Through your website or Google or some other site? All this information will help you better augment your residencies, your brand's digital presence. And I think my time is now up. I hope this was helpful. Thank you again, everyone. And please contact me if I can be of any further help to anyone out there taking on a similar project. And you can always view our video at our website, bayshoreem.com. Thank you.